Welcome to the Crackin Backs Podcast. Today, we're joined by the renowned Dr. Gary Gray from the Gray Institute. We will explore the complexities of hip and shoulder pain. We'll uncover what makes these joints so critical, identify early signs of injury, and discuss practical strategies for prevention and recovery. Whether you're dealing with discomfort or aiming to just stay injury-free, Dr. Gray's expertise will guide you through the essential steps to keeping your body performing at its best. Let's get started.
All right. Well, we're totally excited to have this man back because it is football season, NFL season, and we got the fall sports going on. We've got the great Dr. Gary Gray from the Gray Institute online, and we're going to talk shoulder pain and hip pain because everybody wants to talk about knee pain, but we're going to go to the shoulder and the knee. And shoulder and the hip, sorry. And some of the biggest issues are labral tears, which is the joint of the shoulder and the joint of the hip. So, you know what, Garrett, first off, thank you for coming back on the show, man. We so appreciate you taking the time out for us.
No, it's an honor. Really appreciate it. And I enjoyed the last time, and I'm confident I'm going to enjoy this as well. So appreciate it.
I wouldn't go that far, but thank you for at least giving us the opportunity to rise to your level a second time in a row, because we usually hit it out, and then we'll see what we can do for the second half.
Gary, let me start by asking you what first of all, a labrum, from the layperson that listens to this podcast that doesn't know what it is. I think of it like a washer on a faucet. The labrum is that cartilage ring there's 5 different types of meniscus like that, and so if you can go ahead and elaborate on what we're going to be referring to a lot as the labrum, and why has that captivated you?
Yeah, I think I love that description, because a lot of people, we talk about the capsule and we talk about the capsular ligaments, we talk about the labrum, and it gets a little confusing. But I love the idea of what you just said. It's kind of like a rubber washer around the edge of the joint that seems to be the connective point of everything. Kind of brings everything together. It actually creates a little bit of a seal on the joint, especially in the hip. But it's obviously the attachment helps the capsule and the ligaments attached to the bone, and has, obviously, because it's a little rubbery, has a little bit of elasticity, but it has a point where it says, I can't deal with this anymore, and it tears, and we end up with a labral tear.
Why have you been so fascinated by those two areas, shoulder and the hip?
Well, I think it's because early on in my career, I missed so much. When you get old, you get more fascinated saying, you know what, I think I missed this. Not only missed diagnosing a labral tear, but missed on how to prevent a labral tear. That's a little more of my passion. It's getting a lot easier now to figure out if they have a labral tear, MRI them, squirt a little juice in them and see if there's a leak on the washer. But I'm more excited about, okay, if they do have it, what caused it? Because we know that shoulder labral tears aren't caused by the shoulder, and hip labral tears aren't caused by the hip. So we get excited to say what potentially happened, and can I potentially work with my athletes prior to having this and do my best to try to prevent it. We can't prevent it all, but I think a great percentage of them are quite preventable once we understand the biomechanics of what happens.
It was interesting because I'd say, oh my gosh, 15 to 20 years ago, we had a quarterback at Miami Dolphins that was having hip pain, and it was also converging into the groin area. And I mean, everything was being done. And it wasn't until one of our athletic trainers was very astute, and he says, let's do an MRI, and boom, it was the labrum.
Yep.
So, if you could share with us some of the presentation that a patient might have with maybe a hip, or, I want to keep going back and forth, hip and shoulder, but
sure,
it's
up
great to you, but the joint capsule as well is, how would you make a determination on joint capsule versus labral?
Well, what's really fascinating, let's start with the hip. the hip, the hip's power move to load the musculature is going through internal rotation and the big butt muscles and even the iliopsoas, slowing that down, getting loaded and explode, going through flexion, obviously the big butt muscles and the hamstrings, loading and helping explode. And of course, adduction, the big hip muscles, tensor, and loading and explode. And so when our hip goes through flexion, adduction, and internal rotation, that's a good thing because that's how we load for throwing, that's how we load for running, that's how we load for anything. And when that motion, any of those three motions, and of course they occur in a combination, when they occur, we have these huge muscles to decelerate it. And so there's like a safety net out there. In other words, it's really rare to go too past those three motions. And therefore, you rarely hear about a posterior labral tear on a hip. And that's kind of might scratch your head and go, that's funny, you're right. Most of them are in the front, right at 11 o'clock and 1 o'clock, right in the groin area. And so I wonder why that is. And so when you look at the musculature anatomy of the three opposite motions, hip extension, hip abduction, and hip external rotation, you say, okay, which of you muscles know how to decelerate that? And they're all real quiet. We call it the front butt syndrome. In other words, your front butt, if you look at it, ain't very big. And so we could all get naked if we wanted to and look sideways in the mirror and go, by golly, our back butt's bigger than our front butt. I wonder if everybody else is like that. And the answer is, yeah, we rarely see somebody with a bigger front butt than a back butt. And the reason that is because we're designed to create power. We're designed to resist gravity. We're designed to absorb shock and to take advantage of ground reaction force and mass and momentum in order to load those muscles to turn on proprioceptors so we can do all the fun things we want to do. However, sometimes we have to do something very productive when we get extension out of that hip, when we get abduction out of that hip, and when we get external rotation out of the hip. As indicated, there's a couple muscles in the front of the hip that if trained can help us with that. But when you go and look at the labrum and then you look at the capsular ligaments, they're aligned to decelerate those three motions. It's kind of cool when you look at the anatomy of the hip and the labrum and the capsule and the ligaments. The muscles are designed to decelerate flexion, adduction, internal rotation, but the anatomy of the ligaments of the hip with the labrum are designed to decelerate extension and abduction and external rotation. But when you think about it, those three motions don't occur a lot because they're not gravity driven and they're not ground reaction force driven. However, when they occur, when we do a certain thing, and that's where we're seeing a lot of mechanisms of injuries, we do a certain thing and we have at least two and usually three of those motions occurring together. If we have not created an opportunity to teach the trunk and to teach the foot and some of the hip muscles to decelerate that, the next layer it's going to go to is the ligaments and the labrum. If they don't have the ability to decelerate that, something's going to tear and your rubber washer is going to tear. You're going to get a tear of the labrum and you're going to say, doggone it, I wonder if we could have prevented that. And that's kind of the $1 million question. I believe most of them are preventable. Now, I don't feel the same way about the shoulder. I think the shoulder's at more risk because it has more mobility. The glenoid fossa is a lot, shallower. We do, again, strangely enough, most of the labral tears are, like a slap lesion. They're superior or anterior. Every once in a while, when somebody gets a repair, we see them in that weird looking thing where they have to do a posterior repair. But, 95% we see like this because they did an anterior repair. So you got to ask yourself, okay, wonder how come? I wonder. And so we call it the front butt syndrome for the shoulder. We have a front butt here, not very much thing going on. That's quite bony, little peck here going over and, not a lot of excitement going on. But when I go back here and go, I got some good posterior deltoid going on, rhomboids. And, so my back butt of my shoulder seems to be designed to decelerate gravity again and decelerate and help me pick up things, rocks and stuff. And it helps me do that. But when I get in that susceptible position again of flexion and obviously external rotation and in this case, more kind of an abduction, all of a sudden, we ask what muscles can decelerate that. And obviously, pitchers have to use that to load and explode. And if we don't have good elasticity and good, what we call anterior stability, mobility with strength and stability, then all of a sudden, it goes through the ability for the muscles to control it. It goes right into the capsule and the labrum, and the labrum gets torn. And so, again, our passion is to say, what is the mechanism of injury? Is there a common thread that we can see? We started, there have been labrum tears for years. Shoulders, we've been understanding them, at least during my 50-year career, we've talked about them. But hip labral tears, we didn't start talking about them until about 15, 20 years ago. And I think they were out there. I just think we couldn't diagnose them. And we called it early arthritis, and then that led into a total hip. And, we called it all kinds of things, but we do know that that booger ached right in the groin. And so now we get that classic, they go, when I'm sitting and I stand up, boy, it aches right there. I take a few steps, feels gunky. I walk a little more, doesn't feel too bad. They engage the muscles. They gain a little bit of control that the labrum should be controlling. But then when they kind of slow down or do more static things, it becomes more of a problem. Our eyes light up and go, have you had an MRI? Early on, it was interesting. I'm quote unquote, I don't like this phrase, but it's a phrase people use. I'm just a physical therapist. So I'm not a radiologist. I'm not an orthopedic surgeon. But it doesn't take a Rhodes Scholar to look at an MRI and see where it's leaking. And so we had a documented case of 20 people who came to us that had classic labral symptoms. Now, the tough thing about labrum, there's not really a clinical test that I know of that I can really take it and say, I think there's some instability there. Even if they know, most labral tears, the athlete won't tell you when it happened. They don't know. It's kind of this slow fade. It's a small little baby tear, no pain, and it tears a little more, and pretty soon they started having symptoms. So we would ask for the MRI. We'd throw the MRI up on our computer, and we could see it. We're cheating because we know what we're looking for, but we look at 11 and 1, and we see, bingo, we got a little bit of squirting going on. In other words, it's not holding it in there. So I have a specialist that I utilize in California, Dr. Snibby, one of the best orthopedic surgeons in the world relative to labrums. And he's been kind enough to say, if I get an MRI, can I send it to you and it'll take you 2 seconds to look at it and tell me if I'm right or not. And so a while back, radiologists didn't know how to read the labral tear. So we kind of had to do that for them. But now they do a great job. Now we're they know what to look for. And so it helps a lot to have that diagnostic ability.
Let's back to the hip regarding a common comment from patients would be snapping hip. What is that?
Well, it can be a lot of things. You can have a stable hip and still have something kind of snap. You get a little tendon that's taut and it sneaks over the edge of a bone or edge of a rim. Kind of the big snap, the big thud that we'll see with labral tears is somebody who has an advanced labral tear. That instability where that washer isn't holding things in, and they literally get the hip loads because of gravity and ground reaction force. And then when they take a step, it unloads, but it doesn't unload smoothly. It unloads with a snap. There's a quick movement. So a snap all by itself isn't, a bad thing because we got a lot of snap, crackle, and pops going on in us. But when it correlates to, like you indicated, something going on in the hip and the achiness of the hip and that groin pain, or just a little higher than the groin, then we go, okay, we got maybe a little more instability here than we thought.
We would like to thank Guardian Grains for sponsoring the Crackin Backs Podcast. These ancient grains are made to keep your gut happy and healthy. Check the description below for a link to their many food products.
Now, you mentioned earlier that there really isn't any testing, any orthopedic tests for identifying a labral issue, but so often I see people, have the patient lay supine and they take the leg and they do like all this passive range of motion thing. How do you feel about that?
I think it's great. I think I try everything.
Yeah, yeah.
I lay them supine, prone, sideline, upside down, wiggle it, just try to get an idea if there's a consistent area of pain or if I can slide it a little bit and then compare to the other side. And it very probably is that I don't have the expertise on how to do that. But if somebody's doing that and they can kind of get a positive correlation between what they find, I think that's great. They need to let us know what it is, though. Because I'm not good at it and I can't really differentiate it. I think once I had a person that I took and I did kind of a medial glide. What I tried to do is take the head of the femur and jam it through where I thought the labrum was torn by driving at the knee and driving at the trochanter. And in my mind, I felt I was getting a little more slippery going on there, a little something going to sneak into there. But then I went to the other side and I wasn't sure. So I think it's a difficult one because the hip intrinsically is pretty stable. And when you get that labral tear, muscles around the hip can really protect it for a while. But then, man, you lose that intrinsic stability and that thing starts wobbling back and forth. You get the early arthritis. And now you're in trouble. So an early diagnosis and get that baby repaired so you inhibit the arthritic changes, I think is really key. And I'm seeing a big turnaround. I've seen the orthopedic surgeons around here and just even around the country understand that much better, and they're doing just a great job. And then the key then is to understand, okay, how did the labrum get torn? Because that's when I rehab somebody, I need to know that. So I've gone to some professional football teams and I'll ask the strength coach, so tell me what your job is. What do you mean? What's your job? Well, I'm the strength and conditioning coach. I'm responsible for getting these guys stronger, faster, hornier, meaner, tougher. Oh, great. Perfect. That's your job. Then I'll ask, is part of your job while they're in the weight room to create exercises to try to prevent labral tears? They kind of look at me and they go, well, I'll answer that for you. Yes. Okay. That's your job. I don't have a labral tear now. I'm a $40 million a year athlete and I'm lifting weights. And so is your job to understand what I need to do to give me the least amount of chance to tear my labrum? And the answer is yes, can't deny that. And then the tough question is I'll ask them to say, so what causes a labral tear? Dead silence. And so it's hard to prevent something unless you know what causes it. Same thing with ACL. I'll say, tell me what causes an ACL tear, because you can't prevent it unless you know what causes it. Same thing at the shoulder. So understanding the biomechanical mechanisms that let the labrum down at the hip and the shoulder are really critical to not only trying to prevent the silly things from happening and designing programs that will really help the athlete, but then if they do have rehab and definitely surgery after rehab, our job is then to prevent it again. We're reading a lot now of labral tears re-tearing. And so when you do the surgical repair, did you fix the cause? No, you just fixed the symptom. You still don't know what caused it. And so another interesting thing and this is hopefully most of what I say is based a little bit on fact and truth and sound principles, but this one is a hypothesis, so take it as a hypothesis. I've seen a number of athletes with a labral tear in their right hip, and I find the cause in the left hip. In other words, I see the limitation in the left hip that forced the right hip to do too much because the pelvis. And so you guys know that relationship, but a lot of people don't. And so one of the things I do in rehab is to make sure, I know you had a surgery on your right hip, and I know what I gradually want to do to get that mobile and strong. But at the same time, I'm going to look at the left hip to make sure that wasn't the booger. Many times the foot is at fault. So I'm going to make sure I'm going to look at the foot. And you guys nailed it last time we talked, the importance of the thoracic spine. The importance of the thoracic spine in preventing labral tears is huge. I mean, huge. But very rarely will people like you guys do a great job connect the dots. And so we basically say, well, instead of playing a guessing game here, So I'll ask the strength coach, how much do you do where you drive the hip into extension with weights overhead behind you? How much do you do to drive the hip into abduction? And how much do you do to drive the hip into external rotation? And more importantly, how do you do all three together? What exercise will I do here? And they'll look at me and says, we don't do anything like that. It's not in the strength and conditioning book. It's not in the, it's not in the playbook. And that's where we go, hey, I think we can help you. I'm glad we're here. I'm glad you invited us, but I think there's something that we can do together to give these kids a better opportunity to play the game they love and not get torn up.
Is that where you showed us those lunging type moves last time? Is that those?
Yes.
That's the key. Okay, I love
Yeah,
that. That was a great recipe.
Yeah, what's really neat about that is what we showed you last time is kind of a single plane 3D maps.
Yeah.
So we took our lunge forward, took our hands up and back, getting good hip extension. And then we took our foot sideways and took our hands opposite. We got good hip abduction. And then we took our foot, did a same side rotational lunge and took our hands. We got good external rotation. But we now have what's called 3D maps hybrid, which simply means it's the combination of all three of those motions. So it's interesting as I'm getting older and older and older. I always kind of say, well, if I don't have a lot of time and I only have one exercise in the world to do, I can only do one exercise. I will do what we call our 3D maps fascial exercise. Because what we can do is go through a motion that creates all three of those motions that are at risk of the hip, load them and explode them, and then come down and then load all three motions of the back butt, which is flexion, adduction, internal rotation. So I'm getting all three motions of my thoracic spine. I'm getting all three motions of my hip. I'm getting all three motions of my shoulder. So it's kind of like, there's a movement that you can do to actually facilitate almost every joint in the body in all three planes of motion. The answer is yes.
That's fantastic. I want to go, I know I'm going to dig back a little bit deeper into our conversation about you mentioning that the most common injury to the hip labrum is anteriorly or in the front. And I do recall having in the past the maybe one or two times that I had patients that came in with a labral tear in the posterior region was because of a car accident.
Very good.
They were in. And
usually it's got to be an external force, the old dashboard injury. Yeah, you got it.
Yeah, fascinating. So how often would you be able to identify where there's two conditions where either the capsule has invaginated into the joint because it's so loose that sometimes, traction or some of the activities that you shared with us would help. And when would you also find a patient that maybe has like osteophytes forming on the lip, on the anterior lip? So they say that they can't even bring their knee up to their chest when they're laying supine. You see those?
It's a bite. It's a huge bite.
Yeah.
The problem is that we can get the bite with the osteophyte, and we can get the bite because when we bring our leg up, we need this ability for the femur to kind of roll down in all three planes of motion the other way, so we don't get that anterior impingement. Now you got if that's happening a lot, it's going to build an osteophyte, and now you got a big problem.
Yeah.
So now you got this huge bind going on, and like you say, I think if I can do a little distraction and do a little glide, get a posterior glide and do a little medial glide and get just a pinch of external rotation and get them to actually have more flexion. Usually I'm dealing with the labral capsular problem. Usually by the time it's an osteophyte, I can't make it better. In other words, so I'll do a manual therapy as you just properly discussed. And if I can kind of alleviate and they can get me more motion and they don't have that impingement, then I go, okay, we can work with this a little bit. I'm not as concerned as that you do have this big honk of spur bone hanging out that's going to just beat on the anterior part of the femur between the acetabulum. So, but even then, I'm not always confident. It's one of those where sometimes the big question is, hey, looks like I have a labral tear. Do I have surgery or not? Okay, that's a question. Some people with a slight labral tear, because they move and are very active, they do quite well until they tear it a little more. So whatever the initial mechanism was, now it's more susceptible. So early on, we kind of scratched our head and says, well, maybe therapy and rehab will do it. Well, we're finding out, especially with active people, best thing to do is get that sucker fixed, and then try to figure out what caused it, and then do great rehab on both hips, both feet, and the thoracic spine. And they usually do pretty good. But to differentiate between the spur and no spur, for me, that's hard.
When you request at the point where you go, hey, we need an MRI, I think I should really start with saying that the art of the physical exam is lost. Obviously you're very conscientious and you understand ranges of motion and muscle testing and biomechanics and everything. But man, there's so many doctors that would just go straight to MRI. Oh, you got a hip problem? Let's go. And I want to make that clear, because they've used MRI as a crutch for their, I hate to say, their inefficient ability to perform a valuable, hands-on, observational physical exam.
Yep.
Do you notice that?
And orthopedic surgeons would admit that. There's none of them are going to say that's not true. But then if you have an orthopedic surgeon who's a friend and they're willing to just open up, say, do you know how to do a really good manual examination to differentiate, to see if you think they are a MRI candidate, or this could be something taken care of by a movement practitioner? And they'll be honest. They'll go, no, we didn't learn that. Right. We just know that if there's any suspicion, our job's easy. I get to go see the next patient. And meanwhile, this guy goes to the MRI, and then now somebody else is going to tell me what the problem is. Where, what you all do is what I want to do. I want to understand it and see if they really need that. We can always do an MRI a week from now.
Right.
We can do an MRI a month from now. Nothing's going to get a lot worse. We rarely will somebody have a tear and then we go, oh crap, we didn't do it quick enough and now it's twice as big. Rarely happens. So we have time, and sometimes we'll have referrals and say, hey, we're not really sure it's an MRI, or it's a labral tear. It's kind of acting like one. We haven't done an MRI yet. Can you get this guy on a good exercise program to see if you can get better and see if the ache goes away? And then if you do everything what you consider right to facilitate healing in that area, and they still don't get better, then let's go do an MRI. I agree with you 1,000%.
Do you usually
Gary?
Sorry.
You mentioned that it's been mentioned like an osteophyte. So we know that osteophytes are the body's reaction to abnormal stress. So right. And we have a torn labrum. We know that's torn because of abnormal stress. So I'm not a big keen guy personally on surgery on labrums, because if you don't fix the cause of why it tore or why this osteophyte's there in the first place, you're not going to have success for a surgery. So, right. And so many people get myopically focused on, well, there's a impingement, or there's an osteophyte, there's a tear. Let's strengthen the muscles around it. Well, a lot of people don't think about the feet. They don't think about the kinetic chain. How do you use this osteophyte as a great diagnostic tool, looking for the abnormal biomechanics, and how do you use where the tear is to look for the abnormal biomechanics? How do you use these injuries as diagnostic tools to fix the problem?
Well, he also said he looks at the opposite hip too, the good hip.
Right. Yeah. So let's talk about the feet. Let's talk about how everything works with the hip.
Yeah. Well, what's interesting, and it's good kind of we're sticking with the hip capsule, because it's different, and the labrum is different at the hip than it is at the shoulder. Again, sometimes when I say things, I don't kind of preface it with, and this is my hypothesis. But this is my hypothesis, okay? When we see athletes who have this problem, I always say, well, I need to look at you to try to figure out why. What's unique about you that, you're not able to be a down lineman and handle your duties of protecting the quarterback when all of a sudden you seem to get thrown back and rotated in this way. We got film where the offensive lineman will say, this is when I felt something. They don't say tear, but I felt something give in my hip. And again, we go, that's interesting. They were extended, abducted, and externally rotated by the defensive lineman. And all of a sudden that went. So how much are you training yourself to help decelerate that? Well, most of the time, none. I'll ask them, tell me what you're doing in the training room. And they, we just weren't aware of it. It's nobody's fault. But the interesting thing is when we see what I think people who are susceptible to this, and as Dr. Terry says, it's from abnormal stress. I think the lack of anterior capsule mobility leads to the lack of posterior capsular mobility, that when I then go through my flexion, it doesn't allow the posterior glide and we get the impingement. So I rarely see what I would consider just what I would consider posterior capsular tightness. It's more common for me to see a dominant anterior capsular tightness, lack of extension, abduction, external rotation. But then because it is that washer, well, if you make a washer smaller in the front, it's going to tighten up in the back too. So now the washer gets tight in the back, and now all the things I should normally be able to do, and that's, squat down and flex. Now I don't have that normal roll and glide, and now I'm in a bind. And so as Dr. Terry said, well, should we maybe spend a little time on doing that before we jump to surgery? The answer to me is yes. If we can create that, because we know there's a lot of kids out there that have a labral tear, they don't even know it. If we lined a zillion people up, there'd be maybe a small little labral tear. They're dealing well with it. Hasn't got to the point where it aches and it makes it unstable. And so, is there a more logical diagnostic process, and then a more logical treatment process that we should be doing in some cases, not all cases, as opposed to high MRI surgery? And the answer is yes, there should be. But the problem is, at least myself included, very few of us understood what caused it. So it's really hard to treat it if no one really sat our butt down and said, I think it's an anterior capsular tightness that causes a posterior capsular tightness. I think it's an inability to decelerate extension, inability to decelerate abduction, inability to decelerate external rotation. And if we can create mobility and stability with those three motions, all of a sudden now we see posterior capsular loosening up, and now we get less to actually no impingement. And so it's interesting to think of a balloon. You tighten up one part of the balloon, the other side is going to be tight too. And so we always think, well, how in the world do we get that posterior tightness? I think it's from gravity, sitting all day long like I'm doing right now. Everything's gunking in my anterior hip, and I'm now susceptible, I think, to a labral tear.
Do you ever see precursors to labral tears being maybe an ankle sprain, a thoracic sprain, or even maybe a glute sprain?
Oh, yeah. In fact, I think you just hit the major three. So I did a little talk yesterday just on low back pain, and just I spent most of my time just talking about the glutes and the hip and how it relates to the low back. And you guys taught us that. You guys basically are the masters in that. And when I first started studying the foot, it intrigued me because the foot by design is designed to actually create rotation in the hip. So when I walk, my subtalar joint, when it everts, has this bone on top called the talus. That let's all kind of in our mind vision and think of the right foot. So my right foot hits at the heel, and now it's going foot flat. Gravity and ground reaction force will evert my calcaneus automatically. There's not a muscle that does that. Because of the shape of the subtalar joint, that talus falls down and in. And the key is falls down, but it rotates. And that's why they call the talus a torque converter, because it converts frontal plane torque into transverse plane torque, and vice versa, top down transverse into frontal plane. So if we all stood up right now and just rolled our feet in and out, we'd see our body twist. And you'd go, well, that's weird. I'm moving my foot through the frontal plane. Why is my upper body dominating the transverse plane? Because that's a torque converter. And so when that foot hits and I go through that flexion, I want that internal rotation. And like you just said, ankle sprain. Okay, somebody will come to us and say, got a little something going on my hip. Tell me more about what's going on. No big deal. Last year I had an ankle sprain. We go down there and we grab their subtalar joint, and it doesn't evert. Okay, that's so much. So the two motions ankle sprains don't get back. The traditional inversion is eversion and dorsiflexion. So if their foot's hitting the ground and the talus isn't falling down and in, they're going to get the flexion. They're going to get the adduction from gravity, but they're not going to get the corresponding internal rotation. That's setting it up for the impingement right there. So it's like, boy, before we jump to conclusions on what's happening at your hip, let's create some mobility in that subtalar joint and allow that torque converter to take your femur and rotate it. So now you can get up and under the edge of the acetabulum and you're off to the races. Thoracic spine, if like the motions, I'll stand up, and again, obviously without video, we have to kind of imagine what I'm doing here. But if I stand up and I basically take my right hand and I go back, if I don't have good thoracic extension, where's it going to go? Right to my hip. Okay. If I go over the top of my head in reference to my left hip, I don't have good lateral flexion, where's that going to go? Right to the frontal plane of my left hip. And more importantly, if I do this where I rotate and I'm trying to get my right hand to rotate right, and my thoracic spine doesn't give it to me, guess where it's going to go? It's going to go right to the hip. And so we go, oh, that's a bad hip. And the thoracic spine, like you guys said last time, is up there going, oh, crap. It was my fault. I'm the friend who let him down. And here's what really the thoracic spine's saying. I hope and pray that somebody finds me, because if they don't find me, they're not fixing me.
Right on.
You're still susceptible to the labral tear.
Yeah.
It's so funny because when we have patients, and I'm sure you see this with hand injuries and wrist injuries, we spend so much time strengthening them post-injury. Yet when we have an ankle injury, we do a little bit of strengthening and balancing, and then we put them in soft shoes and arch supports. And we wonder why these feet don't fix, and then we wonder why they have ACLs and hip problems and mid-back problems. So it's amazing how many people forget the feet and forget that whole kinetic chain and all that.
I think we all forgot the feet. I know in school, when I reflect back on the feet, I remember it was the last chapter in the anatomy and kinesiology book, and we only had a half a day, and the teacher said, now listen, there's not going to be a lot of questions on your state board. Memorize it has 26 bones, and you're good to go. And it's like, okay. But then I realized that when patients came to see me, most of them had feet on. And I go, crap, I wonder what those two things are doing. And then I realized it's the only part of our body, the organ that interacts with our environment every step we take. Yeah. And then I go, oh crap. I wonder what it's doing. And then what I did is I looked back to see what they told me it was doing. And they told me what it was doing on a table. I'm not interested I've never had anybody have an ACL tear while watching football on the couch. They just haven't come to me or sprained their ankle. So we started studying 50 years ago when the foot hits the ground, what changes. In fact, we did a course that's still out there. We started a course back in the late 70s, early 80s called When the Foot Hits the Ground, Everything Changes. Yes. Everything. How muscles function, how the foot functions. And like you said, Dr. Terry, a lot of times we just forget about creating motions and reactions in the foot and ankle so it has the mobility and stability so the knee doesn't have to take the hit, the hip doesn't have to take the hit, the low back doesn't have to take the hit, and the thoracic spine doesn't take the hit. That's why years ago they invented the BAPS board. The BAPS board is this weird shaped board that gives you proportional amounts of plantar flexion, dorsiflexion, inversion, eversion, ab and adduction with gravity and ground reaction force. So it's forcing all 12 muscles that send their tendons across the ankle and subtalar joint to do what it's supposed to do. But mostly it's saying with Gary's body weight on this thing, with wiggling like this, it's going to create strength in the foot and ankle. But then that strength is going to help stabilize the knee and the hip. And I need to declare this. I invented the BAPS board, so I don't want people to go, oh, cool, go get a BAPS board. So that you have to take that with a grain of salt.
Yeah, that's phenomenal. I want to switch a little bit while we have some time to the other labrum on the upper, the shoulder. We touched a little bit about it, but it's a structural different. You have a ball and socket, and one's open, one's more closed. Let's talk about the complexity of the shoulder labral, because you talked about the shallower cup, and how we differentiate between a labral tear and bicep tendon and rotator cuff.
Yeah. Well, now we're getting into where I've seen people do great diagnostics, clinical diagnostics, where they can kind of see, I think you got a long head bicep tear, or I think you got a little bit of superior labral tear, or I think you got a little bit of posterior instability. And believe it or not, all of a sudden we do our test and do some of our imaging, and they're correct. As you indicated, just the shape of this thing and the thing what it needs to do in space is huge, and it constantly puts it at a disadvantage. Now, just as Dr. Spencer indicated that we're going to get a posterior tear in the hip if we do, like, how often do we get a posterior cruciate ligament injury? Very rare, but if you get in a car and your tibia's jammed back, we'll get it. The same thing, if I'm in a car and my femur gets jammed back, it'll go right through that posterior capsule. Yeah. The shoulder's kind of similar to that. When you get in certain things and they're doing where they get that posterior jam, you'll get that. But we still see, over the last 50 years, clinically, we see more things happening superior and anterior. Strangely enough, the three motions that I just did for my hip are the exact three motions that put the shoulder at its most susceptibility. And so, coincidence? I don't think so. And so, again, I'll ask the strength coaches and physical therapists and athletic trainers and people that are designed to help make the shoulder nice and strong and stable, how much do you create deceleration with flexion with overhead abduction and with same side rotation, and then all at the same time with some speed and with some weight? And they'll go, well, we don't. We do these goofy rotator cuff exercises that we're not sure why we're doing them. Somebody told us to do that 50 years ago, and so we're still doing it. And then I'll ask, well, why would you want to make the scapula in sync with the pelvis and in sync with the feet, and therefore be in sync with the thoracic spine to put the shoulder capsule at less of a risk? And again, if you don't know the connection like you guys do, that's a foreign question to you. But again, if I don't have good thoracic motion, flexion, good hip extension right now, and good ankle dorsiflexion, guess where it's going to go? Right to my shoulder. And same thing when I go through the frontal plane. If I don't have that good frontal plane motion of abduction of my hip and adduction of the other hip and lateral flexion of this and eversion of one foot and inversion of the other one, where's that going to go? It's going to go right into my shoulder. And then obviously the same thing with the transverse plane, which might even be more significant. So we're definitely more susceptible. The question is doing the right quote unquote shoulder exercises. I'm not even sure if I have in the last 40 years given anybody a shoulder exercise where quote unquote they isolated the shoulder. I always integrate it with the scapula talking to the thoracic spine and the rib cage, and them talking back to the scapula. And any really cool shoulder move, for instance, if I get up and I have a pickleball racket in my right hand and I'm doing a backhand, well, if you say to the shoulder, what just happened there? The shoulder would say, I did very little. My left hip did everything. And so my left hip says I flexed, I adducted, and I internal rotated, the thing we just talked about. All the muscles in my back butt are lengthened eccentrically. They're turned on by the proprioceptors. So now I just snap my pelvis and the arm goes for the ride. And so I look down at my foot and go, oh, cool, my foot has to do something too. My hip has to do something. I need both type 1 and type 2 motion of the thoracic spine. I need the scapula to be able to load and explode. And if we allow those parts of the body to be successful, the shoulder gets a big smile on its face and said, man, you just took the risk of my labral tear down by a lot.
Very good. Do you see frozen shoulder at all?
Yeah. We see them because we're kind of a last resort facility. You know, at the Gray Institute here, we have the blessed opportunity of seeing people who don't get better, and they go, wonder if the goofballs and Adrian can figure it out. And sometimes we can, sometimes we can't. So we'll get the ones where they'll come in and they have a frozen shoulder and they've had it for a long time. So yeah, we get to see them.
what do you do?
I beat the piss out of the pelvis and the scapula.
Wait, say that again?
I shouldn't have said it that rudely. I beat the piss out of the pelvis and the scapula.
Yeah.
And I let the humerus be passive. Very typically, when I ask what kind of therapy have you had, it's I've been laying down, everything's been stabilized. They're grabbing my humerus and they're jamming me to try to get more motion. And the question you got to ask yourself is that how it happens? Never. Okay. So why am I doing that now? Well, because I think I can get into the frozen shoulder better. Well, why don't we let the proprioceptors do the work here? Why don't we put in the 6 motions of the shoulder according to the hip and the thoracic spine and the feet? Why don't we put those together? And why don't I teach the body to use the hip to decrease the frozen shoulder? And then I just take it along for a ride. We call it functional man reaction. I try to reinforce with my hands what happens in function. And the reason we get to see so many of them is because it's not that we're smarter than anybody, but it's very successful because I'm using the foot, the hip, the other hip, the thoracic spine, the other shoulder to treat this shoulder, where most of the people have just been isolating that shoulder to try to get rid of the frozen shoulder. So we cheat. It's called cheating. Integrating the body in a chain reaction the way it was designed to, and let that create the right mobility between the scapula and the thoracic spine to now create the mobility in the shoulder in order that my frozen shoulder goes away.
Hey, Gary, can I interject? Because I'll get these patients that they come in with adhesive capsulitis, which is frozen shoulder, and they're like, yeah, our doctor or our therapist said, well, there's the 3 phases of it. Was it the freeze, the thaw, and I always forget the other one because I don't really pay attention. But they have the 3 phases, and they go, there's nothing you can do. It'll heal on its own. It could take anywhere from a month to a year, and they just but you just brought up. You beat the piss and then they'll go, oh, I beat the piss. They're cupped. They do ART. They get in there and they try and break up the capsule. And then they go, well, if that doesn't work, we can put them under and do manipulation and anesthesia. You're breaking up the piss of the opposite hip and leaving that alone. Can you go? And does this work at all phases? Do you start this right away? I mean, does it? So, and what's your time frame?
Well, I'm weary of phases because everybody's different.
Yes.
So I'm not a real fan of phases. And again, you have to be like you guys have been. You got to be clinically savvy to ask some key questions. When did this start? What do you think happened? Do you even have an idea? Did it start slowly? Did it seem to get frozen quickly? Was it irritated first? Have you hurt any other part of your body? Have you been trying to protect? I mean, just ask some questions to at least give you a start. And then based on the functionality, you go, okay, do I believe this scapula / humerus? We actually call it the peltruncularis. The pelvis and the trunk and the scapula and the humerus. If you put those, sounds like a dinosaur.
Okay.
So we call it the peltruncularis to keep us in mind. So we'll go after, like, for instance, the 3 tough motions of a frozen shoulder. Internal rotation, I can get to here. Okay. Interesting enough, frontal plane, getting the hand back is tough with adhesive capsulitis, and over the top are tough. So both frontal planes are extremely tough. Transverse plane, internal here, that's kind of how they're holding themselves. So that's not a tough one. External rotation, that's a booger. Okay. Extension, a little bit of problem here. Flexion, huge problem. So when you just simply look at, and I'm demonstrating my right hand moving, if I do a forehand in tennis, it's my same side hip that I need to pay attention to, because that's the guy that's going to let the pelvis rotate, let the thoracic spine and rib rotate, let the scapula get properly loaded, so I then can come through and hit a forehand. Makes sense, because all you have to do is do it and you see it. And then you go, well, what about a backhand? Well, the backhand's the opposite side hip. Well, that's interesting. What about going from extension to flexion? It's the same side hip. Well, that's kind of weird. How about if I load and explode into abduction? Now it's the opposite side hip. So what we'll do is we'll say, okay, go ahead and stand up for me. We'll get the pelvis going. Let's say I'm after abduction. And we get the pelvis going in the frontal plane. So now they're adducting into the right hip, but they start adducted left hip and they load and explode. The scapula should follow where the pelvis goes. So the scapula will get loaded like the pelvis and then it'll explode up. That glenoid will come up real nice. The humerus will go down and go, oh yeah, this is what we do. And now we just create mobility there by creating the appropriate motion biomechanically that the shoulder was designed to do. If you give the shoulder back its authenticity, it's going to come back 10 times quicker than laying them on a table and cranking them.
Super good. Wow. So those are probably one of the most difficult conditions. And you just shed light on a completely different perspective on managing this frozen shoulder thing, because they're really tough. And if you look it up, it's the only condition that they say to work through the pain, but it is a miserable way to do it that way versus the way you're just suggesting.
Yeah.
So I like
believe it or not, the rule I have with my patients doing it that way, because I did it the other way early on in my career, and I'd look at them and say, this is going to hurt you a lot more than it's going to hurt me. And so, here's a stick to squeeze on. I literally tell them, if I'm doing it right, you should have zero pain. Not only zero pain, but zero discomfort. If I get your body working in synergy, your butt's gonna cure your shoulder problem long before I will. So yeah, I'll feather it a little bit. I'll get a little bit of thoracic. I'll take the scapula and play with it, and I'll feather the humerus a little bit. But it's rare that I put more than 20% force into the humerus and mostly 80 to 90% force into the thoracic spine and the hips. It's rare that I have to create a driving of this. And then what's really cool is once they achieve this new range of motion, if they kind of hold on to something, then they drive their pelvis in all three planes of motion. Yeah. I get that distraction and I get all three planes of motion, and they come back and they've gained 20 degrees on their own. They've been stuck for 4 months, and now within 2 days on their own, not me doing it, they gain 20 degrees on their own because they're using the pelvis to create the mobility in the shoulder. They go, what in the world did you do to me? And I go, I didn't do anything to you. You're the one who did it. You should be proud of yourself. Now I'll teach you how to get the rest of it, but that's where it gets fun, when you empower them to do it themselves. And that's obviously a good adhesive capsulitis. You want them to attack it a few times a day without pain. Pain's one of those things that pisses everything off. Yeah. And so this rebound effect of pain, I'm not sure that's the best treatment for a shoulder that doesn't want any pain.
Gary, what do you do other than motion, other than having the patient do their own biomechanics? Is there anything manually you do to maybe restore proper motion to the thoracic spine and ribs and all that, like a foam roll or something? What do you give them?
Yeah, no. So as I explained to you before, early on in my career, I knew how stupid I was, and the bad news is how stupid I would continue to be. And therefore, I snuck into all kinds of meetings. And a lot of them were chiropractic meetings. A lot of them were osteopathic meetings. And a lot of them were manual therapy meetings of therapy groups. Yeah. North American, mobilization, Australian, everybody had their own thing. And I started scratching my head and going, why is there different ways to achieve what we want to achieve? And that's the right motion at the right joint at the right time in the right plane. And so we thought, well, wait a minute. Why does my thoracic spine even move? Well, it moves because my eyes move, or my hands move, or my foot moves. It doesn't just go, hey, look what I can do. Rarely does your thoracic spine say, hey, I'm going to show off a little bit here and just do a wiggle and giggle. And so we take a look at that and go, well, if I do this with my right hand, I'm getting right rotation. If I'm doing this, I'm getting left lateral flexion, and that could be with extension or flexion. So we'll literally go in there and reinforce that with our hands. We call that functional manual reaction. This is not hypothesis. This is something I would argue quite adamantly. You can be a manual therapist and understand all your rules of manual therapy based on whatever certification you just passed. But if you don't know the biomechanics of human movement, I would contend you're not a manual therapist. Because the whole idea of manual therapy is to reinforce normalized motion. Nothing else, nothing more, nothing else. And So for instance, if you believe you can mobilize the SI joint, but you can't tell me what the SI joint does when I'm swinging a bat or walking or running in all three planes of motion, I'm not going to let you touch my SI joint. And same thing, if you can't tell me what the thoracic spine does, like a golfer, thoracic spine's a big inhibitor of the golf swing and the number one cause of low back pain in golfers. So if you can't tell me what it's supposed to do in rotation and lateral flexion top down and lateral flexion the other way bottom up, and if you don't know that, then there's no way you'd be able to get in your hands on me and to reinforce that. And that's the beauty of what you all do, and hopefully what we do is if we just let the body do it, it'll follow the path of least resistance. And they'll just reinforce a bad pattern of motion, and we're getting nowhere. So we got to get in there and snarl a little bit. We gotta kind of get in there and move it a little bit, which is that's kind of exciting. But once we create that new mobility, then we got to be smart enough to teach them how to maintain that new mobility with strengthening and stability exercises. So I did that wrong for a number of years early in my career. They get great mobility, I'm happy with it, and they leave to come back to worse. I'm going, well, crap. This is maybe I'm just doing the mobility things wrong. And then just logic says, wait a minute, if you create new mobility, you better strengthen it, or it's going to act as a hypermobile segment and an abnormal, and it's going to basically respond by clamping down, going the other way. So the beauty, I think, of what most of us now know is based on years of mistakes. And I'm number one on that. I'll match anybody in any profession relative to how many mistakes I've made, and I'll kick their butt. They only come close to me. But I got to be smart enough at the age of 70 to go, do I still want to continue to make those mistakes, or would I like to learn more about how the human body really functions, and would I like to do a better job? I've chosen the latter.
Yeah. Hey, Garrett, a lot of athletes like protocols that like something simple to go through. With football season coming on, we get a lot of dislocations, from receivers to quarterbacks, linemen, even linebackers going through running backs, grabbing their arm and throwing it back. What's a good warm up to get the shoulder ready and stabilized to reduce injuries? And what's a great couple exercises for a cool down before they hit the showers?
Yeah, well, you can go to the Lions and see it live. I mean, our friend at the Lions, she's done an amazing job, and the whole team has. And when you look at their training and conditioning now, it's a lot different than traditional training and conditioning. And so if you just said simply to me, what's an easy way to teach an athlete to at least start a foundation of strength of their shoulders? I would go, well, we would do what we did 50 years ago. We would do the 3D shoulder matrix. And you'd say, well, what does that mean? Well, anytime you hear me say matrix, it's three planes of motion. And anytime you hear me say three planes of motion, it's both ends. And so if I was going to take just a bunch of young kids, let alone my high-end profile NFL players, and say, if nothing else, when you do your overhead press, do me a favor, go forward with it, and then go backwards with it. Now, as well as going up, go to the same side with it, and then go to the opposite side over the top of your head with it, okay? Now, instead of going just straight up, open up and rotate with it, and then cross over. So I just did a shoulder matrix. So if I ask my shoulder joints, this is my superior muscles of my shoulder, what did you do? They say, we just did everything. Okay, that was easy. I just did all six things. And I think that's why, first of all, we've been successful over the last 50 years. But I think that was one of the first strategies we realized. If the body moves in three planes of motion, we better create exercises in three planes of motion. And therefore, years ago, we developed hundreds and hundreds of matrices. One of them is, as you guys mentioned, the lunge matrix. I just showed you the shoulder matrix. We have, you name the activity, you name the body part, we have a matrix for it. And I think that's a neat way to get started. Now, what the Lions then do is add movement of the legs. So they add the lunge matrix with the shoulder matrix, what I call in sync and out of sync. So sometimes that's where most of it, my body's going that way, I'm reaching for a ball this way. Oh, crap. Have I prepared for that? Most of the time is no, but they are preparing for that. So I would basically say, well, am I doing basically a same side rotational. At the same time, I'm doing an opposite side rotational with my foot. So my pelvis and my foot are going that way. But all of a sudden, I made a cut, and the goofy quarterback threw it behind me a little bit. Okay. And so I don't go, well, I'm not going to reach for it. It might hurt my shoulder. I'm going to go, boom. I'm going to reach with my lower body going one way, my upper body going the other way. Here's what our hope and prayer is, that their body, their shoulder, the thoracic spine, their hips and feet and their neck go, been there, done that, no problem, catch the ball, bring it in. It's like nothing ever happened. Nice. But if you haven't trained in that, what we call transformational zone, or in those combined motions to give you that, what we call abnormal movement, then there's a good chance for injury. So it's fun to just, because you got to make it simple, at least for me, if I'm going to work out. And so teach me a little bit of lunge matrix. That's easy, all 6 directions. Teach me a little overhead matrix. Teach me to do them in the same plane. Teach me to do them opposite, have a game with it. And now I got a party.
Gary, those are great. And I'm so glad you left us with that, because that's something that people can start doing immediately, those kind of movements and entertaining those biomechanics. We're going to wrap up, but our usual rapid fire questions are now there, 5 of them.
Yeah, we had fun last time, didn't we?
We did have a great time.
Yeah,
we did.
I got to tell you though, he's sitting right next to me.
Yeah,
and I had him listen to the podcast. And first thing he told me is, first of all, those guys are brilliant. They really listen and they ask great questions. I said, yeah, I know. That's why I enjoyed it. And he got a smile on his face, and he says, and I was just happy they asked me to be on the show. So I just want to let you know that he wanted me to tell you thank you.
You're welcome.
You want to show who he is real quick? Is he right there? Right? Yeah.
Oh yeah, he's right here. He knew you guys were going to be on here, so he goes, I need to watch these guys. They're good. And I go, I know. I'll let you sit over there.
Well, we could say he should answer the rapid fire questions if you wanted to, but I'm gonna be totally leave that one up to you, Doc. Yeah.
I'll go normal voice now.
Normal voice. All right. Question number 1, Gary. Your secret to longevity.
I like that, because we've been talking a lot. Well, against the older you get, the more you start talking about that.
Yes.
I didn't talk about longevity when I was 30.
No.
Those are just a bunch of old people who are going to die soon. Good luck to them. Yeah. Well, he brought it over here, so in case we do have to have it, in case he doesn't need to say anything. And actually, this guy is 50 years old, so he's kind of been holding together pretty good.
He looks good.
Longevity is kind of defined in a bunch of different ways, but I think kind of the thought process now is I want to live quality longevity. I would rather live 70 years of quality life than 90 years of being beat up and can't do what I want. Now that sounds maybe a pinch morbid, but that's my own personal feeling. And so when we think of our world, the world we get to work with, and the people you get to work with, longevity is directly proportional to the ability to move. So funny, I did a survey of longevity clinics. So if you type in longevity clinics, they're all over the place. And they're popping up everywhere. And what I did is I did a number of things. I wrote down the names of all these, and I think I got through 12 of them. Some of them had the word longevity in it, health, wellness, well-being, all kinds of stuff like that. But it basically meant live longer and have a more productive life. That's, So then I wrote down what they promised. So on the website, what they're going to promise me for my longevity. Then I wrote down all the objective tests that they do to evaluate me to determine what I need to do to live longer and a healthier life. And then I wrote down all the things that they would teach me to do on my own so I could live longer. So I wrote it all down because I wanted to see what they're doing. The number one thing all of them were missing was movement. And at the end of the day, movement is king and queen.
Yes.
Because give me cancer and the ability to move any day, okay? Right on. Take cancer away from me, but don't give me the ability to move. I want the cancer back right now. So it's like And that's why I think what you guys are doing in the movement chiropractic world, especially you guys are way ahead of the game in preventative. Letting me come in and create the mobility in my joints so I can move better. You guys are way ahead of the curve there. Okay.
Yeah.
What's going to happen is you guys are going to even be more significant because people are going to realize without movement, there's no longevity. Okay. I might live, a sit down in the front of a TV life for a while, but that's not pure longevity. So longevity is mobility and stability and a ton of laughter.
Yeah.
Laughing at ourselves, not taking ourselves too important, understanding what ultimately we're living for. And I think just helping other people. And that's what you do every day. You guys wake up and go, hey, I'm going to serve my patients and clients. And I think that creates a youthfulness that kind of keeps a lot of us going. So that was a long way to say, it's got to be giggling and moving.
There you go.
Very good. I think we're going to change the topic of rapid fire to maybe.
I think if anybody said I asked Gary a rapid fire question, they would just laugh their heads off.
What?
He's never answered a question
right?
in his life.
But you're so right, though. I heard recently relationships and exercise being movement are the key to good relationships, obviously, are the key to longevity, indisputably. Question number 2. Oh boy, I feel this could be a big one too.
Wait. For a sec, Gary, I do have to go to work sometime today, so you got to keep these kind of rapid.
You got it. That put in perspective. I appreciate that. It was a very kind way to say. Okay. Here we go. Donald can answer quicker.
Gary, what do you
What's the second
one? What do you? I'm trying to ask. What do you want to be remembered for?
I'd like to be remembered for being a good friend.
Oh, that's nice.
Just being there when I've been blessed with a lot of friends. I'm not sure I always am there for them. That's one of the things as I'm getting older, I'd like to work harder on. And I just want to be remembered as somebody who cared. And obviously I consider my patients and clients friends, and my family friends. So I just, we're all going to be forgotten in a number of years. That's think about your great grandpa and tell me what color eyes he had. You don't know. So if there's a small term memory, I just hope that somebody would say, I think he was kind of goofy. I think he laughed a lot, but it seemed that he really cared for his friends.
That's good. Absolutely. That was good, Gary. What is your favorite exercise that you do every day?
That's easy. It's the 3D fascia matrix. What I'll do is I'll do the 3D maps initially to get all the planes done, and then I'll go through the whole diagonal with gradually try to increase the weights. And I just did 3D maps with some resistance going into and out of the transformational zone about an hour ago. So I want to do things that are effective and efficient. And so if I can get every joint and every muscle and every proprioceptor turned on in less than 3 minutes, that's what I'm doing. And that's what I do every day.
I'm so curious. Do you do it against resistance at times?
Yes.
Like a
I do it with free weights at times. Yeah, I do it with a Viper at times. I do it with pulley at times. I do it with ampliphotonic bungee cord at times. I'll do it with medicine balls at times. I'll do it with a core ball at times. So I like to mix it up.
Question number 4: the answer could be dangerous to your future in this in your profession. What is your favorite NFL team?
Yeah, that's a tough one.
You don't have to answer on the grounds of incrimination.
As you guys know, your experience in the NFL, these kids are amazing.
Yeah.
I mean, unless you get down on the field and see them flying around and hitting each other, you can't appreciate it.
Yeah.
And all that goes in behind the scenes, the chiropractors that work with the NFL teams, the therapists, the massage therapists, the nutritionists, the athletic trainers, just all the people that are literally giving their life to make somebody else look better.
Yes.
You know what I'm saying? I think that's the beauty of it. And I gave a big talk to the athletic trainers for the NFL. I said, listen, I just want to tell you, I admire you because you spend your whole life giving everybody else the limelight, and you ask for none, and you work your butt off and you work hard hours. So, I'm not going to answer that one because we're some NFL teams don't even know who we are. Yeah. Some of them have invited us in and to speak and talk. We just want to be known as somebody that would help. And so, and I grew up in Indiana. So, and with a lot of people who like Michigan a little bit, a lot of people liked Ohio, a lot of people like what's happening in Indiana. So I was a confused young boy. I wasn't the typical kid that wore the same outfit all the time. So I would say I'm pretty neutral.
Well, that was a safe answer. And the last question, best joke or story you tell someone to get them out of a funk.
Best joke or story?
Yeah.
Well, it kind of depends who it is and what kind of language I'm allowed to use. Let's see. I usually try to come up with an authentic story based on what they just told me that doesn't degrade me but makes fun of me. In other words, if a patient or client comes in and they're telling me something's going on in their life, I try to internalize that and I try to think, okay, I don't want it to be about me, but based on what they just said, I can tell them kind of a funny thing that I did that didn't quite work out well to at least get them to smile, and basically see the threshold of smiling. See how quickly with the behavioral driver I can get them to go from I'm in a lot of pain and discomfort to you just made me laugh. So it's usually not a key. It's usually different for everybody. And of course, being 70 years old, you got all kinds of goofy stories of goofy things that I've done. And so it's pretty easy to come up with something. So I just I want us to become friends quick. And therefore I want to hear their heart and I want them to hear my heart. And so I'll usually tell them a story that is a little bit personal that just makes them laugh.
Super good. Gary, it was a pleasure having you on the show again. I look forward to seeing you soon. You bet, man.
Now, it's none of your birthdays, is it?
No.
No, okay, because Donald was going to say happy birthday, but if it's nobody's birthday, then...
Okay, I won't do it, okay?
Okay. You can say bye-bye to him.
Bye-bye. Thank you.
Okay. Guys, it's been an honor. You guys do an amazing job. Keep it up.
Thanks, buddy.
You bet.
Okay, thank you.
Thank you for listening to today's episode of the Crackin Backs Podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.